Okay, so in this video, we're going to go through a little bit more of a detailed assessment of the posterior cuff to see how well the scapula and the humerus can dissociate from each other, okay, which requires the posterior cuff to lengthen, okay. So we're going to use a test called the Tyler test here, okay, which can be done in a supine position. It can be done in a sideline position as well. But essentially what this entails is us to fix the position of the scapula to allow for the dominant segment to be the humerus moving through the range of motion. So in the horizontal adduction test, we could see how it's very easy for the client to protract the scapula to try and gain more motion so they can reach across to touch the opposing shoulder. We're also going to see elevation of the scapula as well. But in this position here in supine, I like the supine position because it allows the client to already be in a position where the scapula is more externally rotated. Okay, so this would be the right scapula here. We're looking for that scapula to be more externally rotated where the glenoid faces more laterally. I'm actually going to come in with my hand and press right on top of the lateral border of the scapula to keep that externally rotated. And then what I'm going to do is I'm going to grab Connor's humerus, or grab Connor's forearm and then guide that across, so we can do it passively. Or what we can do is we can ask Connor to actively move the humerus across into horizontal adduction. And what we're looking to see here is, can that humerus break perpendicular? Okay, so can it move across the body? Okay, so this would be a perpendicular humerus relative to the table. We want to see how well the client can reach across the body. Okay. Now this would also oftentimes couple with if someone is limited, this would also couple with an inability to move the humerus through internal rotation, which would also require the posterior cuff to lengthen as well. But what this looks like, just to show you here now, I'm going to grab the heel of my hand, position the heel of my hand right on top of the scapula. I'm going to position that down, so I'm going to push down to the table to externally rotate. I'm also going to adduct the scapula as well, so I'm almost trying to externally rotate and then push it inwards to really fix that scapula towards the spine so it can contribute to the horizontal adduction. Because if Connor was to reach the elbow, that's dragging the scapula up into protraction as he comes across the body. That probably feels very easy to bring that across the body, right? But if I was to push down with the heel of my hand, that's bringing the scapula into external rotation and pushing towards the spine. I can start with the humerus a little bit more horizontally abducted. Okay, so I'm not starting with the humerus in the perpendicular position. I'm giving him room to move that humerus through horizontal adduction, but what it also does is it makes it easier for me to bring that scapula into external rotation and adduction. Because if I start here, the scapula is more than likely going to come through protraction and internal rotation. So I'm going to position that in here. I'm going to maintain the force of my hand, again checking with the client to see that it's comfortable. Is that comfortable there? Yeah. I'm going to have Connor do it actively first. So I'm going to keep the position of my hand pressing down and in. I'm going to guide Connor's forearm. So I'm going to have Connor reach across the body, just making sure that it's staying in horizontal adduction. And you can see here, we're just getting to that point where we're perpendicular. Okay, do you feel a kind of a lengthening or a stretch across the back of the shoulder? Yeah. And if I passively bring you further forward, yeah, we're reaching kind of a block right there. Okay. So if the individual cannot break that perpendicular position, we are suspecting that the individual lacks that muscular variability through the posterior cuff. Okay. Again, we also have to consider the posterior capsule as well, but we want to consider this within the context of other assessments too: shoulder flexion, standing horizontal adduction too. Okay, so let's look at this relative to the left side, because we do want to compare both sides. Again, if we have a client coming in with right shoulder pain, for example, and they have a limitation in the lengthening ability or the variability of the posterior cuff on the right side, a lot of people will say, well, again, both sides are different, they shouldn't be symmetrical, but we do want to try and push towards that ability to demonstrate variability on opposing sides of the body as well. Okay, just to give us something objective to work towards. Okay, so let's look at this on the left side. So same thing, we're going to position the humerus into a little bit of horizontal abduction from sagittal plane into horizontal abduction. I'm going to position the heel of my hand on the anterior border of the scapula, pushing down externally rotates the scapula, and then pushing in adducts. And starting here, I can have Connor can bring the humerus across into horizontal adduction. And much different there. Does it feel like it's moving across a bit further? Yeah. I can give a little bit more passive adduction as well. So we're certainly able to move through a greater range of motion on that side. Okay. So we can, again, consider this, of course, within the context of the client's other subjective and objective features. We're not going to try and pin the individual's pain experience down to a limitation in the ability of the posterior cuff to lengthen, for example, but it's just information that we can utilize to guide our thought process and guide where we may want to constrain force and load into, and what kind of muscular behavior we want to express as we're delivering that stress, applying that stress and load to the system. Okay, so like always, if you have any questions, please let us know below.